Okay, so welcome everyone. Today's speaker is Tullia Padellini. Tullia is a postdoc at Imperial College working in the group of Marta Blangiardo in the School of Health. And she's talking today about assessing the impact of deprivation and ethnicity on SARS-CoV-2 infections in England. There you go, Tullia.
Thank you. Thank you so much for the invitation. Thank you so much for having me here. And yes, today I'm going to present this work that we have been doing as part of this data analytic and surveillance group, which is funded by the UK HSA, which is the UK Health Security Agency. Basically, this was governmental research, and I've been doing this together with a bunch of amazing people. And Marta Blangiardo, that Silvia mentioned before, is my supervisor, but then there is also Radka Jerstakova and Ruleman, Peter Diggles, George Nicholson, and Silvia Richardson, who have been key. So, right, yeah, cool. This is something that we've been doing as part of this statistical modeling and machine learning laboratory, which is a joint venture between the Royal Statistical Society and the Alan Turing Institute, that were contacted by the UK government and were asked to basically provide some modeling insights on COVID. Here are just a bunch of people that are working on this. And if I were a senior person, this is probably the time where I would be like, come and join us. This would be the recruiting bit. But honestly, this is a really great place to work, and they have a lot of openings. So I know that if some of you are junior and are looking for another place, that could be a great opportunity. So basically, we were asked to do something about COVID, and in particular, we were asked to look at inequalities with respect to COVID. Of course, has been quite a while since COVID has been around, so we weren't the first one to look into this, and there is quite a lot that we already know. The first and most important thing that we know is that actually when we talk about inequality, we typically mean people from with an ethnic background or coming from a deprived community. So we already know that ethnically diverse and more deprived communities have been differentially affected by COVID. And by differentially actually mean they have been more affected than white or wealthier communities. There is this study by Public Health England, which was basically the predecessor of the organization I'm working for now, which found that there are higher test positivity rates for people from Black and Asian backgrounds. And also, this is about mortality, that people living in the most deprived areas in England and Wales were twice as likely to die from COVID-19. Of course, this is already showing you two of the problems. So we have multiple outputs to account for when we are considering COVID burden. So for example, the first report was about test positivity. The second one is mortality. Which measure is best to still, well, it doesn't really have an answer. So it's a matter of trying to consider them all. And then this, as you can see from the dates, are extremely dated in the sense that there was a lot of work on this at the very beginning, trying to understand during the first wave of the pandemic, whether some communities were differentially affected, but then there was kind of a standstill. And we also know that the COVID burden for BAME, so Black, Asian minorities changed through the course of the pandemic. And in particular, we saw that while in the first wave, so basically March last year, Black community seems to be more affected. During the second wave, the risk for those communities were a bit reduced. And then instead, the community that was the most affected was the South Asians. And these are two very, very nice studies based on this Open Safely platform, which basically records individual level data for roughly 20 million people. And it's about hospitalization, test positivity, and death. So again, like it goes back to what we were saying before of having more than one metric to actually assess the impact of COVID-19. And the other thing that we know is that these two components, so basically socioeconomic deprivation and ethnicity, actually have to be considered jointly, because some of the studies were actually considering only one of the two, but this is of course very limited. And then last but not least, we know that COVID-19 has a strong spatial and temporal autocorrelation structure, which is something that has to be accounted for when modeling, because neglecting to do so will basically result in higher effects of the exposure, which might actually just be confounded by the fact that we're not including the structure, the spatial structure or temporal structure. Okay, so that being said, this is pretty much setting the scene for what we have done. And so after looking at the literature and seeing all this, basically what we wanted to do was to estimate the effect of deprivation and ethnicity on SARS-CoV-2 infections. But since we saw that there was some difference between the first and the second wave, we actually wanted to see whether that was like a different point in time, or if there was some kind of continuous transition. What was time varying effects of these two different dimensions? And we wanted to check whether there were persistent or transient patterns in the infection using a spatiotemporal model, basically. And then last but not least, given that there are very many measures of what cases are or what COVID burden was, we wanted to compare two different measures. And in particular, we wanted to assess the difference between the spread and the monitoring. So what is the difference between, say, the actual number of cases and the number of cases that are detected by the testing programs? This is especially critical because basically we were funded by NHS Test and Trace, which is the organization in the UK that was responsible for testing. So they actually wanted to see whether or not they were doing a decent job at that. So we are trying to assess a COVID burden in terms of a number of cases or SARS-CoV-2 infection, if we want to be more precise. And the way we tried to address the fact that we wanted to compare these two metrics was by basically considering two outcomes. One was cases as basically positive tests. So this we consider as a proxy for the ability of the system to monitor. And it's basically the cases that are detected by some of the testing systems that are in place in England in particular. And then for assessing the spread, we actually wanted to see what would be the effect of those two measures, so of these two dimensions, if we could actually test everyone. And of course, the overarching goal for all of this is always policy intervention, because understanding whether or not some areas have been less targeted by testing campaign, it's of course extremely critical. And I'm a bit I have to say, like, this is very weird for me because this is the first time I'm presenting this work to statisticians. Most of the time we actually present this to policy people or clinicians. So if there is any statistics bit that is missing, please stop me and ask me for more details. So the first outcome that we were mentioning is basically how do we assess monitoring? And we decided that a good way to address it was basically considering test positivity. And in particular, we focus on what is called Pillar 2 PCR test positivity. So why Pillar 2? Because Pillar 2 is the name of the UK government testing program for what we call the wider population, meaning everybody with symptoms or not symptoms. But all these are the tests that are not being carried in hospitals. So basically every test that has been done, regardless whether it's lateral flow device or it's PCR, and it's not been done in a hospital, it's considered to be Pillar 2. And PCR, of course, is the molecular test, and we only consider lab processed molecular tests, and we remove the LF tests from our analysis. We didn't consider them because the policy here is that after you get a positive lateral flow test, you have to get a confirmatory PCR as well. So we decided not to consider LFT in the analysis. And I don't know if you're aware of this, but in the UK, the way the rapid tests work is that they're all self-administered and the results are self-reported. So of course, by considering test positivity and including the number of LFT, we were encountering a massive problem, which is the underreporting of negative tests. Then before introducing the second outcome, which is this actual number of cases, if you will, just as a small parenthesis, in the UK, we have something which is very specific to the UK actually, which is a couple of randomized surveys programs where we try to, and I say we as if I was part of this, but actually where they try to estimate prevalence based on random sampling of people. The sampling design is very complicated, and it's a massive program involving roughly 150,000 households every fortnight. So it's really just like something extremely big. And this basically provides unbiased estimates of prevalence of the number of people actually having the disease at the moment in the country. The problem is that, of course, even though this is a massive program, it's still coarse in space and time, in the sense that, of course, the estimates are by region, and time, well, it's fortnight, and so it's not extremely timely. Plus, it of course takes time to actually elaborate all this data. So we do have estimates, but we have estimates that refer to previous times in some sense. The good news is that these estimates are actually extremely good quality. And so what we can do is we can use them as a gold standard, basically as a measure of true prevalence, and anchor whatever testing data we have to them to debias them. And this is what basically George Nicholson and other people from my group have been doing in this paper, which I will try to summarize in 3 points, but I will butcher for sure. So I strongly recommend that you read it if you're interested. And the idea is to combine this targeted surveillance, which is basically the pillar 2, with randomized surveillance, which is one of these randomized programs. And in particular, we're focusing on one of them, which is called REACT, which comes out roughly every month. The idea, and again, I'm butchering the very fine work that has been done in the paper, it's to infer the prevalence from the unbiased testing data. So basically from the randomized survey at a core scale, and by course, I mean regional. So we have some understanding of what is the magnitude of the bias. And then after we learn this kind of bias, and now it varies over time, we try to project it to get a smaller final resolution level debiased prevalence estimate starting from the testing data. So just by assessing basically reprojecting it. Again, I'm not really going much into the details. What I want to show you here, it's what happens on the top panel, what happens if we consider only the test as a measure of prevalence, and on the bottom panel, what happens when we actually do this adjustment. So here is we're using our model to predict this REACT rounds. So basically the REACT round is when we have prevalence estimates. And what you can see is that if we have them uncorrected, so if we just take the test for that time, the estimates that we get are pretty different from what we actually have. So there is a pretty strong bias, whereas again, this is just predicting. So it's not that we're using the same data to actually infer this, but when we do correct them, we have that the unbiased and the unbiased by definition and the debiased prevalence estimates are pretty much in line with one another. Okay, so I guess that pretty much we covered one of the 3 goals, so there is still a bit more to go. And now in particular, I want to say a couple of words on what do we mean by investigate persistent and transit patterns using a probabilistic spatiotemporal framework. And this is the only kind of statistics bit of the talk. So we are using a spatiotemporal model, and what we mean by space is this lower tier local authority level. There are roughly 315 LTLAs in England. We consider only 312 because we removed some of the islands, because they basically had no test. And as you can see, there is already kind of like a big variation, especially if you consider test positivity. You will start seeing that there is some areas that pop up, and you kind of get the idea that this might be here just for this week. It's not something which is persistent, but it's something which is specific to this week. So we wanted to consider both things. So the persistent pattern, so what happens if there are areas that are consistently above the average, and also can we capture areas that, like, for example, this, I think this is something like Boston or something like that. I don't, not sure, that are have higher value only for 1 week. The time resolution is weak, and the reason why it's because this way we don't have any day of the week effect, because you probably know that COVID tests are reported as soon as they get processed, but this as soon as, of course, varies depending on whether it's weekday or weekend. People get tested less on the weekends, and the test takes more time to be processed. So by considering the week, by aggregating by week, basically we neglect all of this. Plus, I'm not really sure what the benefit of having daily estimates for prevalence really is. And then the time of the analysis is between the 1st of June 2020 to, well, basically mid-September this year. And the reason why we didn't consider a period of time before the 1st of June, it's because basically the very first wave testing access was extremely limited. So accounting for the number of monitor tests with the number of positive tests was not really reliable. So we knew that those data weren't really accurate at all. So we just decided to ditch them. And then what do we mean by a probabilistic framework? So again, this was meant for a clinician. So this is like the layest explanation I can give of the model. So we have our outcomes of interest, which are again, prevalence and test positivity. And we're trying to decompose this into something we can explain. So basically some observed variables and something which is not explained. And we are assuming that both explained and unexplained have some temporal and spatial structure. So basically the unexplained bit would be everything that contributes to the spatial temporal heterogeneity that is not explained by the data that we have, but we assume has some structure regardless. And this is the formula. So basically our response variable, it's just the number of PCR2 positive tests. We model this as a binomial, and the size parameter, it's the number of total process tests, so that this parameter PI can be interpreted as the test positivity rate. For the second outcome, we actually consider Y to be the median number of infected people coming from the rebiasing model I presented. And of course, the size parameter would be the population size. And in this way, PI/TJ can be considered as the prevalence. We have a bunch of confounders. So the exposures, of course, would be, and I'm going to talk about it later, would be ethnicity and deprivation, which are the two main variables we're interested in. And then we have a bunch of confounders to address factors that are correlated to the response, but don't really mask the effect of the exposures. So for the exposures, we decided to use the 2019 which is the most recent up-to-date index of multiple deprivation. This is a combined index which includes very many domains of deprivation. So it's deprivation in income, employment, health, environment. There is even air pollution in it. It's very broad and general. And then for ethnicity, we decided to instead consider as a covariate the percentage of BAME population, so Black, Asian, minority. But we also did a second analysis where we disaggregated by major subgroups. So we consider separately Black, South Asian, which would be defined as people identifying themselves as Pakistani, Indian, or Bangladeshi, and other BAME, so other minorities. And then for the confounders, we included age, which is considered in age classes. Then we consider the urbanicity level of the area, so whether an area is more a city or just plain fields, and the percentage of fully vaccinated people, which we had defined as a person is fully vaccinated if it received one of the mRNA vaccine or the AstraZeneca at least 2 weeks before, the second dose, sorry, at least 2 weeks before, or the first was dose of Johnson & Johnson at least 2 weeks before. Although, to be fair, there aren't very many people getting Johnson & Johnson in the UK, or at least in England. Just to give you a graphical representation of what our exposure look like. So on the left here, we have the IMD score. So basically this deprivation measure that we're using, while on the right, we have the proportion of BAME population. And this is already super useful because one of the first things that we were told was like, yeah, but if you include both of them, they're going to be highly correlated. This is true, but as you can see, the spatial distribution it's quite different. So we have that the north in general, this is I don't know if you can see my pointer. Well, anyway, the yes. North, thank you. Anyway, this area here, which is Manchester, Liverpool, it's the one with the highest level of deprivation. It's like the poorest of the country, and this is something that I didn't know before coming to the UK, but apparently is a well-known divide between North and South in England. Whereas when we look at where the BAME population is concentrated, we see that this is actually London, so which is to be expected, I guess. Then we have that when we actually consider the 3 different subgroups, their spatial distribution, it's pretty different. So we have that, for example, like the Black community is mostly concentrated around London, and maybe this is another way, I don't know how good you can, well you can see it, but basically what you see here is that the Black population is almost all of it is in London, whereas South Asian, it's also part in the north, and especially in Manchester, as you can see here, and this is Birmingham, whereas the rest is a bit everywhere, partially because of the definition of rest, which is literally whatever else. Okay, so let's say that we kind of talked about this second goal, although we didn't really say much about persistent and transient patterns. We're going to get to that later. Let's go to what we said actually was the first goal. So estimate the time varying countrywide effects of these 2 dimensions. And the way we do it, this is again the same model as we've seen before. It's very, very trivial. So it's basically just by adding a time varying coefficient on the 2 exposures. So here we have this x beta, which represent the fixed effects, which is say the overall effect. And then we have this delta, which we model as a random walk 1 over the 1. So basically we say that the effect changes every m is every month, and we say that the effect of this month cannot be too different from the effect of the previous month. So it's basically influenced by the effect of the previous month. We impose sum to 0 constraint on this, so that basically this delta just represent the difference between the effect of the month and the fixed effect. And we have well, this is it's 4-dimensional when we consider the 3 different BAME subgroups. So it's the IMD plus the 3 different BAME subgroups, or it's bidimensional when we consider the aggregated BAME and the IMD only. Okay. And then for the last bit of the model that we haven't explained yet, so as I was trying to say before, we want to differentiate between what are persistent patterns in space and time and what instead are just like transient anomalies. And both of them are actually very important, because we know that a persistent patterns means areas that have been constantly more affected, and so probably areas where you should actually target interventions to kind of compensate what happened there. Whereas transient anomalies are probably areas that you should keep an eye on, because you don't want there to be some kind of domino effect, which is what happened, for example, with the alpha variant, which started from a very specific region, which constantly had, not constantly, sorry, which transiently had higher values and was kind of neglected, and then it spread and it became the alpha variant, or the British variant, or the Kent variant, or whatever you want to call it. So in order to do that, we try to include both factors in the model. So this kind of smoothing component and this instead more unstructured interaction term. And the basic idea for this persistent bit is that neighboring areas or subsequent weeks must have similar values. Whereas basically what we're trying to say with this space-time unstructured interaction is that there is some error that we cannot really explain based on what happened before or what's going to happen next. So for this space component that we are including in the smoothing part, we are using what is called a Youg model, but in a different parameterization, let's say. So I don't know how familiar you are with all of this. This is pretty standard in spatial statistics, but I think it's always worth just recapping what it is. Basically, the Youg or BYM model, it's given by the sum of two components. So it's an ordinary random effect and an ICA random effect. An ICA random effect, it's a spatially structured random effect, which basically is, whose definition is this. And what you can see is that you define the value at each neighborhood conditional on the value of its neighbors as the mean of the neighborhood divided by the number of neighbors basically. And then the variance also depends on the number of neighbors. So basically you would have that the more neighbors you have, the more information you have about what's happening. And so the smaller the variance is, okay? So this, for example, this is London, and this area over here is Camden. So basically what you're saying is that the values that you will observe, whatever it is that you will observe in Camden, are very similar to the values of the neighboring areas. At least they're an average of the value of neighboring areas, because this is exactly the average. And the variance of this value is going to be as much smaller as many neighbors there are. So for example, Camden, it's a really good example because it doesn't have that many neighbors in the end, whereas areas like, I don't know, like Westminster probably has a little bit more if you consider the other side of the river as well. This is inducing some local smoothing, whereas this ordinary random effect is inducing some global smoothing. So basically the idea between these BYM is to have some smoothing in both a global sense and a local sense. This, of course, this ordinary, say, random effect captures some unstructured spatial heterogeneity, whereas this UI, given that it has this neighborhood structure, capture spatial autocorrelation. Then the formulation that we're using here includes this F parameter, which is why this is not exactly the BYM model in its original formulation, but it's this other formulation, which is called BYM2, which it's defined so that the variance of this U component is equal to 1. This way, basically, this bit and this bit have the same variance, which is scaled and is equal to 1 for both terms. And then this rho parameter can be interpreted as a proportion of spatial heterogeneity, which is explained by the structured effect. And of course, this is going to be 1 minus it, just the thing. And this is very important because basically we're saying that if rho is equal to 0, then we have no spatial structure and we don't have to account for it. Whereas when rho is equal to 1, then whatever spatial heterogeneity we're observing depends only on autocorrelation. Of course, if you have a model like this ICAR, even though it's pretty basic, it's a lot more complicated than having just an unstructured random effect. So in general, you wouldn't want to have such a complicated model unless it's really necessary, which is why in our model, and we're Bayesian, we're trying to put a prior which shrinks rho towards 0, so that we are considering a spatial structure only if the data actually say that there must be one. And in particular, the way we're defining this penalty is through the penalized complexity prior framework defined by Hovaru and Daniel Simpson, I think 5 or 6 years ago in a paper in Statistical Science, right, if I remember correctly. Then for the rest of this unexplained bit, we have the temporal effect, which is order to random walk. So basically, we're saying that the value at each time depends on the previous 2 times, and this gives a bit more smoothing than just considering the value of the previous time. And then for the space-time interaction, we adopt the type 1 spatiotemporal interaction, which basically means that it's unstructured both in space and in time. For those of you familiar with the Knorr-Held space-time interaction, we tried them all. So we tried structured in space, unstructured in time, unstructured in space, structured in time, structured in both space and time. And then at the end of the day, the results were pretty much always the same. And this is because, and this makes more sense also because what we're trying to actually see, it's whatever transient pattern there is. So every time we were trying to include spatial structure, basically we were just not getting anything because the spatial structure was already accounted for by the BYM. So there isn't the smoothly varying in time spatial structure nor temporal structure. That, yeah, it's different from the one that we are already incorporating with this random walk too. Okay, so this is basically, I guess, everything that you need to know from the model. Again, it's very simple. So it's just binomial observation, and then we're modeling this logit of the parameter of interest, which, let me remind you, can be either the test positivity or the prevalence with some confounders, then some exposure of interest, which are allowed to vary in time. And then we have something which is just depending on space, something which just depends on time, and then this space-time interaction. you might be wondering, yes, you said that you're going to use this prevalence estimates coming from the model, but you just say that you're going to use them as, well, basically you're taking the median, the posterior median of whatever estimates you have. You can actually do something which is a bit more sophisticated, which is doing a Gaussian approximation of the estimates there, so that you actually have homologic prevalence, and you will have basically the variance of the estimates, and then you can include that variance in your model by just having another random effect. And we actually did that, and you can see this in this other paper that is currently on arXiv. Okay, now some of the results finally, which is, I guess, the most important or interesting bit of this talk, at least for me. So what we observe here, it's in each of these cells, we have the value of test positivity and prevalence after adjusting for all the factors that I talked about before. And in the parentheses, you have the relative value with respect, relative change with respect to what we call the baseline, which is basically an area with low BAME and low IMD. And by low, we actually mean the first quartile. So you can see a pretty defined gradient. So this is not surprising at all. What you see is that when you increase the BAME percentage in the area, or when you increase the deprivation level of the area, then there's going to be a higher test positivity or a higher test prevalence. What is interesting to notice is that actually the two variables do not seem to have a symmetric effect. So overall, increasing IMD seems to be a bit worse than increasing the BAME percentage. You can see like this, it's, yes, not symmetric at all, at least for test positivity, whereas for prevalence, and this we would think is a very interesting result, the effect is more symmetric. So the actual spread, we think it's a bit more symmetric with respect to these two these two measures, which means that basically there is something wrong with how people are tested, or even better, with who is actually getting tested or not. We also can quantify the increase. So basically you have that you go from 2.97 to 3.35, which is actually, I don't know why this is a 1.10, well, it's like 1.11. So it's like you have a bit of an increase here, like more than 10% increase in test positivity, and roughly the same value for prevalence. Of course, that is average over the whole study period, but we are interested in seeing what happens in different times. And what really is interesting to notice here is that the magnitude, so the size of the variables we are considering, changed quite a bit during the course of the pandemic. So basically you have that the test positivity is actually somehow higher now. And this is because we're considering only molecular tests. So people that are taking molecular tests now probably went through a quick test before. And so of course, the number of people taking molecular tests and not being sure is very small. So if you take a molecular test now, it's very likely that you have COVID. So this really tells you something about the different testing pattern that we had. And this instead, you can see that basically there is a lot of a very sharp increase in test positivity in December, November, December, January, which is basically when the Alpha variant came out, and it was a bit of a mess. Here from March to April, it's when the UK government introduced a free testing scheme, for which everybody in the UK can get two free tests per week. And this is actually what you observe here. So now the test positivity increased because there are more cases, but it's also because this new testing regime is in full scale, so full swing, and so people actually trust LFD enough to get tested with us first. When you look at the different profiles, so when you look at what happens for this area of high or IMD or high BAME with respect to a reference, which is low BAME and low IMD, you can see something which we found very interesting, which is basically that the importance of the two variables changes over time. So when we saw the first style, basically this one, we said that, okay, there seems to be a stronger effect of IMD. But when you actually go and look at the pattern over time, then there is something more interesting to be said here. So you have that basically IMD seems to be the most important factor for the first wave, sorry, for the second wave, so first wave after the first, basically like the summer and October, which was when the UK was doing already pretty bad. And then here it's the first lockdown because we were doing pretty bad, the first winter lockdown of last year. And then what happens here is that actually the effects switch. So then BAME becomes actually more relevant into explaining high test positivity. And this basically persists for this whole thing until January, and then IMD becomes more important after that again. So basically what we're saying is that different waves are probably different, say, underlying means of transmission, and in understanding whether more deprived or more ethnic diverse community have been more impacted can tell you something about how and why the wave actually came to be. And oops, sorry, I forgot to mention that the results are for the two different outcomes, so test positivity and prevalence. And although the values are a bit different, and again, we were expecting this because we saw some symmetry in the prevalence that we did not see in the test positivity, overall they seem pretty consistent, especially this switching of importance is still there, which is what we really were reassured by. Then, of course, aggregating all BAME, it's a bit coarse, it's a bit rough. So we were trying to see what happened to different BAME subgroups. And here we're showing what happened. So in yellow, these are this represent basically the time pattern of areas that have high other and high South Asian BAME population after adjusting for vaccine, rural status, and all the other confounders. And you can see that this is pretty much always on top of the other line. So basically means that areas that had high South Asian were constantly worse off. What's interesting, and I'm not sure it's very, very clear, is that the other line, which is always above the one, it's this reddish one, which is basically low other and high South Asian. So basically what we're seeing is that here, the high South Asian was always higher than the reference level, whereas the effect for other, for example, is less clear because it goes up and down a bit depending on the time, which it's basically saying that the South Asian community seems to be the most affected during the second wave, which is what we saw in the previous papers as well. And then this would be the third wave as well. And this is perfectly coherent with the narrative that the Delta variant was actually more widespread, at least in the beginning, in South Asian communities. You might have noticed that I neglected the Black population, and this is not by accident. It's basically because you can see the difference between the same lines, but the dashed one, it's basically the one with high Black population, and the two lines, I mean, the effect of having high or low Black population doesn't really seem that drastic. So you would have that the lines are pretty much on top of each other most of the time. So we decided not to include this. This is pretty much the same for prevalence. Again, the scale of the effect might be a bit different. So here you have that we have an increase of 20%, which I think is a bit more than what we observed before for groups with high other and high South Asian, for areas with high other and high South Asian communities, but overall the story is the same. So you always have that this red and this yellow line are constantly over the level of 1, including the confidence interval and stuff, which basically means that you can pretty much say that those two communities, the South Asian community was the one that was affected the most. And then of course at points was also the other BAME. Same as before for the Black community. So here actually the difference between the line is a bit more noticeable, but it's still nothing compared to what happens when you increase the South Asian level. I mentioned that there were confounders, so let us see what is the effect of those, and especially the vaccination rate, which is protective, and the urban status, which, as you might guess, has the opposite effect. So a more urban area is actually associated with a higher test positivity, and a more rural area is not. This these lines over here should be interpreted with a grain of salt, because this is basically just the fixed effect. So this is just the beta. We're not including the delta bits. So of course, this uncertainty has to be taken with caution, because of course, when you add the rest, it goes kind of here. But what's interesting to see, even just from here, is that, well, the values for the two outcomes are very similar, and there is a clear difference between the South Asian and the other BAME communities. So South Asian really seems to be more affected than the Black Stay and the other BAME. Then we did some sensitivity analysis, and we actually did a bunch. I think we really tried every possible combination of the outcomes, interaction, non-interaction. But here I'm just reporting 3, which I think are the most interesting. The first one, which is this one in yellow, it's basically the same analysis on test positivity, but now we're including the whole pillar 2. So we're adding also lateral flow devices, because we have some delay. So we have some times for which we only have LFTs. And what we see is that the effect of IMD changes quite a bit, which may suggest that there are different testing patterns depending on the deprivation level. And this might also depend on the fact that more deprived areas have more, say, essential workers that have to go to the office more. Again, this refers to the whole study period. So even though now things change here, because basically everybody has to be at the office, this refers to when lockdown was also in place and people were advised to work from home. Overall, we see that anyway, the results are pretty much the same as before. Then we decided to include the lockdown indicator as a covariate, just to see if there was some effects of the lockdown. We know that our temporal trend, and I'm going to show this in a second, actually do capture the lockdown, but we wanted to see if there was more that we were not considering. And actually, it turns out that our temporal trend already does a pretty good job at it. And then the third sensitivity analysis that we performed was removing the vaccination rate from the confounders. And this is depicted in purple. And I mean, as you can see, nothing really changes much, at least not for the variables that we're really interested in. So going to the persistent spatial trend. So what we see here is the overall spatial distribution. So on the left, it's basically our predicted test positivity. And then we can disaggregate this into the covariate effect. So this explained spatial heterogeneity and whatever is left. So the spatial residual is basically what we defined before as unexplained. What turns out is that the covariate explained 25% of the overall spatial variability, which is actually pretty good considering what few covariates we had. And when you look at the spatial residuals basically and compare it with the explained map, you can clearly see that the covariates explain pretty well the behavior of the cities, and in particular of London, which in the residual here on the right basically disappears. Whereas what they don't seem to capture equally well, it's the north. So here again, the areas of Manchester, it's still higher than the national average, and probably there is some other confounders that we did not include that should be accounted for in the analysis, or other factors that we missed. We actually know that the Northwest has been hit the hardest. It's under discussion why. And this is what happens for prevalence. So for prevalence, the results are pretty similar. The only difference, so there is a general agreement with the maps that we've seen before, as in the covariates basically explain most of the variation in the cities, but they don't seem to pick up all of the north. There is a small difference here in the northeast, but we're not sure whether this is due to the fact that there are fewer people on the northeast. So the prevalence estimate that we get from the randomized survey might be less reliable. Again, this is under investigation. We are not sure yet. For the time trends, again, I just wanted to highlight how our time trends actually capture the lockdown. So you can see this super steep decrease in the shaded areas, which are lockdown times. And then last but not least, this is very, very quickly, this basically represents how many weeks an area was considered to be anomalous for each quarter. So basically this space-time interaction I was mentioning before. And the only take-home message here is that here you basically can see pretty clearly. So here we had outbreaks in the north, which we knew. And here basically you can kind of see the spread of the Alpha variant, whereas for the Delta variant is a bit less clear. There is less of a geographic pattern. The Alpha variant is that it's called the Kent variant, and Kent is here. So one more slide on how to be careful when interpreting these results. So first thing first, as I said multiple times, we only consider PCR, so molecular tests, but actually the results change quite a bit when we include LFT in the temporal trend in this last bit. And this is because of this trend testing habit. Then the data that we're using on ethnicity are not really up to date because they come from the census. And then last but not least, this is the problem with all area level studies, ecological fallacies. So area level association might not reflect the individual level. So no one should interpret this at the individual level scale. So going back to our original plan, we wanted to estimate the time varying countrywide effect of deprivation and ethnicity on SARS-CoV-2 infection. And we saw that there is an effect, and it's a negative effect on both measures. Deprivation seems to play a larger role in the second wave, while ethnicity seems to be more prominent during the third wave. So we have this interesting switch. And we have that the effect of ethnicity is not the same for all ethnic groups, but areas with high percentage of non-Black BAME population were more affected. The second goal we had was investigate persistent and transient patterns. And we basically saw that the Northwest has some of the highest level of test positivity and prevalence, while the Southwest has the lowest of both. Well, Southwest is Cornwall. They basically lived in this state of bliss until G7, G20 happened there. And then they had cases, but that was a very short-lived thing. And then we can see from the space-time interaction that the spread of the Alpha variant seems to have a clear spatial pattern, which we knew, whereas Delta didn't. Finally, we were trying to assess the difference between spread and monitoring of the pandemic. And what we can see is that the results between the two outcomes are pretty consistent, which means that basically it's disease exposure or susceptibility and not testing access or habit that really explain most of the increase and decrease. There is still this problem of unexplained difference in the Northeast, which again might be due to quality of data for the unbiased prevalence estimate. And I'm done. Thank you so much.
Thank you very much, Tulia. Very interesting talk. So there is time for a quick couple of questions. I can start. I have a curiosity. Maybe it's a stupid question, but then have you thought about just splitting the data, as London is so different from the rest, and then it seems that you have a completely, so the geographic structure wouldn't be homogeneous, and I know that you're using this kind of model exactly for this, but just have you tried what happens if you separate London from the rest?
Yeah, actually,
just because you have that relatively high residual values for the Northeast.
Yeah, so actually we did, at the beginning, we were actually fitting the model separately for London and for the rest of the UK. But it was a bit iffy to justify it because you cannot really, I mean, like there is the population of London is so large and the number of people that gravitate in London is so large that it was a bit, when we presented that to policymakers, they were a bit like, yeah, but we cannot really do much with this.
Yeah, makes sense, I guess.
Yeah, it was more of a practical decision than yeah, that's a good point.
There's time for another question. Okay, so if there's no further question, I guess we can all thank Tulia, and if you want to ask her anything, you can find her online. She has our website, so it's easy to contact her via the email listed there. Thanks again. Oh, and it's also here in the slide, sorry. Thank you again, Tulia, for joining us, and thanks for the seminar. Bye-bye.
Thanks for having me. Bye.
Bye.